My name is Rob Gray. I'm an orthopedic hand surgeon in practice in the Chicago suburbs, and this is part of an instructional course lecture that I moderated at the Hand Society in 2014 in Boston, entitled Elbow and Wrist MRI, Critical Tools for the Hand Surgeon. This is my section on clinical correlations for how I use wrist MRI in my practice. I have no relevant financial disclosures. So these are the top few reasons I order an MRI on patients. Far and away, it's to evaluate snuff box tenderness in a patient with normal x-rays who at 2 weeks is still having pain. I usually splint them or cast them for the first 2 weeks, take them out of the splinter cast, re-x-ray, and if they're still having more pain than I'd like to see around the snuff box, to get an MRI. I use it to evaluate ulnar-sided wrist pain when I'm thinking about operating on them and not before. So if I'm looking for a UT split tear, TFCC tear, ulnocarpal impaction, or ECU subluxation. I use it to evaluate for an occult ganglion or Keen box in the case of dorsal wrist pain. I use it to look at scaphoid vascularity and sometimes lunate vascularity, but this is dubious. There have been some good studies that shed doubt on the concept of using an MRI to look at vascularity of the bones in the carpus. And I often use it to buy time. If I'm not exactly sure what's going on, I need to think about it a little bit more, I send the patient for an MRI. So what surgeries get indicated by an MRI in my practice? Well, fixing a scaphoid is number one. TFCC debridement or repair, and UT ligament split tear repair, ulnar shortening osteotomy, ganglionectomy, vascularized bone graft for scaphoid or lunate. Again, this is dubious. The best test is to actually look at the bone intraoperatively. Hook of hamate excision, if I find that there's a hamate non-union, or carpal tunnel synovectomy if there's quite a bit of synovitis in the carpal tunnel. But also, it should be noted that if you find a subluxating ECU tendon on the MRI, the ECU subsheath is torn, then ECU tendon stabilization is one that often gets indicated by an MRI. So scaphoid fracture, again, is the most common MRI that I order. There's a JBJS Britain article that is from 2005, I believe, that shows the cost effectiveness of ordering MRI in these patients that are 2 weeks out, still have wrist pain, because you can save them further immobilization and further serial radiographs if you can exclude a scaphoid fracture. And by the same token, you can get them back to the OR sooner if you determine that there is one, rather than waiting for it to show up on the x-ray. The T2 or fat saturated images tend to be some of the better ones to look for. You look for the blush of fluid in the bone, which indicates a fracture. You can find the fracture line more easily on the T1 images. Here's a non-displaced one that I fixed with a screw. Here's an MRI from a patient I had recently. The x-rays did show a fracture. I could see it, but it looked non-displaced. It looked like the distal pole was split in half, and then there was a fracture sort of at the distal third junction. But it really didn't look that bad on the x-ray. And on the coronals, it didn't look that bad either. But you see on the sagittal views of the MRI that the scaphoid is in a ton of flexion. It really looks like a humpback deformity, and it was far more displaced looking than anything else that I saw. So this patient I actually took to the OR, and intra-op, it looked just like the MRI it showed. I was able to take a few x-rays, standard x-ray views, didn't look displaced. This one here showed the scaphoid and quite a bit of flexion, so I fixed her with a couple screws. Scaphoid non-union, low signal is often used to demonstrate proximal pole AVN, although this is, again, dubious. You can have a high blush fluid signal during an inflammatory phase in a dead bone, so that can be confused for a living bone. Alan Bishop has a great study where this wasn't the point of the study, but as part of the study, he took the scaphoid out of a dog wrist, froze it in liquid nitrogen to kill everything in it, coated it with crazy glue to make sure that nothing could grow into it, put it back into the dog wrist, and got an MRI. And on every one of them, the MRI showed that there was vascularity into the bone, which was clearly dead. So something to keep in mind. Surgeries for non-union, most of them can be fixed with a percutaneous screw. You can do cancellous graft or structural graft as needed. But I often favor vascularized bone grafting. Here's a picture of a free medial condyle graft, which is my graft of choice for non-union with AVN. So scapholunate and lunotriquetral ligament injuries are often found on MRI, but in my practice, if you need the MRI to find it out, I'm probably not operating on the patient anyway. The study that indicates surgery for me on those much more than an MRI is an X-ray. I look for a gap, and if I see a gap on the X-ray, then it's something that I think that I need to address. Here's one in concert with a distal radius fracture. So they got a plate and screws and some suture anchors. You can't see them; they're radiolucent, but backed them up with a cross pin. Ulnar-sided wrist pain is often a reason that MRIs are ordered, but I don't do it to start with. As we all know, this is a challenging entity, and these patients often have problems that have been ignored by a lot of people, and so their personality types can be a little challenging. It doesn't mean that there's not something wrong, and it doesn't mean there's not something you can't make better, but I would try non-surgical options first exhaustively. So it's really, for me, when all else fails is when I'm getting the MRI. So I've done a few steroid injections. They've had NSAIDs by mouth and topically. I've put them in a Munster splint, and when they still fail that, and they have a positive ulnar fovea sign. Dick Berger taught us this, that it's very high sensitivity and specificity for a UT ligament split tear. Pain up in the ulnar fovea when you push in and up towards the carpus. Those patients often get an MRI, and in concert with all those other findings, the test can be pretty sensitive for something you can fix. So this is a case, patient is ulnar positive, complained of ulnar-sided wrist pain, had this little cyst in the lunate, and the MRI showed a blush in the lunate consistent with ulnocarpal impaction, and then also a concomitant TFCC tear. Usually the tears are central, they're degenerative, but they can avulse off of one of the origins or insertions. Check the lunate and the ulnar head for signs of impaction, like this blush in this lunate. If you had the opportunity to get a 3 Tesla MRI, I would do it. The sensitivity and specificity both go up quite a bit, and the pictures are just much better to look at. So, assuming that you have this constellation of ulnar impaction and TFCC injury, what are your options? You can repair the TFCC through the scope with an extracapsular repair or an all-inside anchor. Thermal shrinkage is starting to fall out of favor, although it's still in the literature and is still technically a board answer. And you can do it plus or minus ulnar shortening. I think that ulnar shortening is really indicated pretty much in any one of these cases that you're going to do. We're all trying to avoid the dreaded non-union and the black line sign. But remember that the technique matters a lot. The out-of-the-box ulnar shortening kits have been shown to have a statistically significant, a not quite statistically significant rate of less non-union, but that may be something to think about. Here's one of my cases. This woman had ulnar-sided wrist pain, challenging patient personality. She was slightly ulnar positive and had fluid in the lunate as well as this fluid outside that was indicative of a UT split tear and some ulnocarpal impaction. So I did an ulnar shortening osteotomy on her, as well as a TFCC UT ligament split tear repair. And despite her challenging personality, she actually turned out pretty well. Other options, the Felden or the wafer procedure. Through the scope, you can burr down the head of the ulna to prevent impaction, but that can often be lead to quite a bit of postoperative pain initially. One can do an osteochondral osteotomy, fix it with some cannulated screws. This is not one of my cases. I am not this talented a carpenter. It looks fantastic, but it seems very technically challenging, and it has been described all arthroscopically as well. So dorsal wrist pain, When you have occult dorsal wrist pain, I think at that point you're looking at ganglion cysts versus Kienbach's disease typically. And so that MRI showed a dark lunate, which may or may not be consistent with avascularity. You have different options for local pedicle grafts. This is the 4+5 extracompartmental artery graft that Alan Bishop described from Mayo. My treatment of choice for these before they've collapsed is actually decompression, choroid compression of the radius and the ulna, and I often couple this with a PI enterectomy. So here's another patient where the axial imaging shows a very small ganglion cyst right at the SL interval, nothing that one could feel or see on clinical exam, but these patients often have a ton of pain. And if you're very lucky, every once in a while you can catch it just as you sneak through on the coronal images, but the axial imaging is by far and away the best to find these. I find that surgically they are not very satisfying. You open the wrist, you look around, you kind of really don't find too much. You open the wrist capsule and you make believe that you sort of pulled something out, but it's really hard to see. Close them up, splint them, keep your fingers crossed. They are far and away some of my happiest patients. It relieves their pain substantially, and I find that almost the smaller the cyst, the more pre-op pain they have. People with the big golf balls, as you know, it's plus or minus, but sometimes these infinitesimally small cysts really just cause them quite a bit of pain for whatever reason. So thank you for your attention. Please don't hesitate to contact me with any questions.